4.
Good Saturday morning to everybody, and welcome to HyperFit MD Radio Show. Age management is always the topic of discussion, along with Dr. Charles and Francesca Guglin. I'm Gary Byron. Hey, folks. How you doing, my friends?
We're good.
Nice to see you.
Yeah.
How have you been?
We've been going to the beach.
Oh, yeah, right?
Yeah.
Kayaking, bike riding.
Last few years, last couple of summers, we said Friday afternoons at noon, we're closing the office, so we're going to the beach. And, of course, the last 2 summers, we were working until 8, 9 o'clock every Friday. So we just never got out of there.
Yeah.
And then this summer, actually went through the calendar and just marked off Friday afternoon for every weekend this summer. Because we work on Saturdays anyway, and we wind up working a good part of Saturday. So we just want like one day when we can just like check out, you know what I mean?
Don't we all deserve that?
Right. I think we do.
Yeah.
Work-life balance. That's what we're working. That's what we're working on.
Our kids have that work-life balance.
Well, I couldn't hear you. I'm sorry.
I said our kids have that work.
Yeah, they have it, but you don't.
They figured it out.
They figured it out, man.
Yeah.
They totally figured it out.
This generation, they do an amazing job.
They make sure, you know how like another generation was all work, no play?
Yeah.
This generation
opposite.
knows that you got to have play. You got to balance, like everything.
Yeah.
Moderation and balance. It's just what it's all about. I thought we'd do something a little bit different this morning. And more or less hit the reset button. And the reason why I think it's so essential to do this, particularly with this show, is this show is, from what I've learned, is growing by leaps and bounds. But not necessarily all of the listeners that we picked up along the way were around in the first couple of months, for some of the topics that we had previously discussed. So I kind of wanted to hit the reset button. And maybe do, at least for the sake of this morning, maybe, and if we have to go into next week, we go into next week, but maybe go into some of the topics that I know we've gone through in the past, maybe elaborate. For many people, however, it'll be their first time hearing it. Is that okay?
No, yeah,
all right,
absolutely.
Good. Then let's talk I'll talk about the most basic question that I can ask you pertaining to that is, all right, HyperFit MD, Age Management Center. What does that mean? What exactly do you do? That's a loaded question. I realize.
Well, let's see. We get up and we have a little granola, go running. So age management, it's kind of a, people who do what we do don't often use that phrase in reference to their own practice, but I think it pretty much encompasses everything that we do, because what age management is really all about helping people of age maintain or achieve a good quality of life as they get older. I think that to a large degree, the healthcare community, of which I'm a part of, because I was a surgeon for 35 years before we opened this practice. I'm an allopathic physician, and I've been on that side I'm still on that side of the fence to a very large degree. But the attitude seems to be that once a person reaches a certain age, men, we've talked about this before, going through andropause, women going through menopause, it's considered normal. What is normal aging? Normal aging on that side of the fence is all about, to my mind anyway, watching a person get older and older, less and less functional, and consuming more and more pharmaceuticals along the way to treat symptoms, as opposed to treating the underlying cause of disease. And age management really is all about helping people, rather than to just kind of go down that slippery slope of old age and then fall out of a wheelchair into the grave, basically maintain a good quality of life as you get older. And it's a full spectrum thing. It's an inside and an outside thing. And we'll talk about that down the road, I'm guessing. But that's really what age management is all about. It's about helping people acquire or maintain health in old age. We talk about health spans in our practice, not lifespan.
Is it more preventative? Are you trying to approach or discuss issues, human issues, that could be detrimental to one's health prior to it occurring, taking preventative measures? Or does it have to do with using alternatives to pharmaceuticals or all of the above?
Yeah, that's a perfect question, because I think that much of medicine in this country is reactive. Okay,
Yep.
you have a heart attack, and then they put you on an exercise program. Okay, you have diabetes, and your doctor says, well, you got to exercise more and lose weight, and they pat you on the butt and send you out the door, and we'll see you next year, or we'll see you in 3 months for your follow-up check and adjust your medications, those kinds of things. So yes, it is really about prevention, but it's about engaging a patient to become a partner and become engaging a patient or to take responsibility from a lifestyle standpoint and from a stress standpoint. Stress kills, and so we talk a lot about stress in our practice, things like that. So yeah, it's very much prevention oriented, but it's also looking deeply, deeply, deeply into what's going on with the patient right then and there, so that you can acquire a system or a set of goals for them with their cooperation, acquire a set of goals for them that you can then work on. I call it chunk medicine, because what we do is we kind of peel off a chunk at a time, and help people get past certain things. So,
Is it more physical? Is it more physiological? Is it more mental? What is it more of?
it's all of the above.
Is it really?
Yeah, it's a global thing. Yeah.
Is it like there's life up until a certain age, and you mentioned andropause for men, menopause for women, and then life beyond that?
Yeah.
Is that the,
Right.
I don't want to say the halfway point, because it's not necessarily, we don't know when we cash in our check here, cash in our chips here,
Right.
but is it life before that, and then that's a line of demarcation, and there's life after that? And what you're trying to do is you're concentrating on the second half, on the life after andropause and menopause.
Yeah.
And also, if you start early, if you create a better lifestyle for yourself at a younger age, you might not create all the inflammation from the abuse that you did younger. So your second phase might be easier.
That's the prevention
Yeah.
aspect of it, really,
Yeah.
to a large degree. Yeah.
What are some of the labs that you do that are maybe out of the ordinary?
Okay. So the first part of any evaluation in our practice is basically a free consultation. Everybody comes in. I'll sit down with them for an hour and just kind of first question I always ask is what's going on? She's heard me say that a million times. First, I always ask, how'd you find us? And then I'll just say, what's going on? That old joke, the doctor says, oh, so what brings you to the office? And she say, well, an ambulance. But anyway, what's going on? And then I sit down, and we talked about this before in previous shows. I sit down, I shut the heck up, because on average, a physician, when asking a question of a patient, and this is a study that's been done, will interrupt that patient within 17 seconds. And the fact of the matter is, if you just shut up and listen for however long it takes, a patient will delineate for you what their concerns are, what they've done about it already, okay, and where they failed, so on and so forth. Then you ask the questions. You want to get their history, their health history, all the standard questions that a physician asks. But then the real evaluation starts with blood work. The blood work that we do in our practice goes way beyond that executive panel that your doc does every year. We look at vitamins. We have a very robust very robust supplement program in our practice. We don't sell anything out of the practice, but we run patients. All of our patients are on supplements based on objective data. Low D, give D. Low B12, give B12. It's pretty simple. But all of these things, and quite frankly, supplements, the allopathic community kind of poo-poos the concept of giving supplements. But the fact of the matter is that supplements are food. They're nutrients that don't exist in the food that we eat anymore. Okay, we look at heavy metals. Many patients that come to our practice have mercury, have lead, There's arsenic in the groundwater in southern Connecticut. People who drink water from wells will frequently have an arsenic level that is high normal, we'll say, those kinds of things. We look very deeply into autoimmune disorders. What is the first thing that a patient will say who's like in their 50s or 60s, or one of the cluster of symptoms that they complain about is fatigue. We always hear about fatigue. They're tired all the time. Many autoimmune disorders that are subclinical, meaning they haven't resulted in symptoms that have resulted in a diagnosis, drive fatigue. So we should look at that before it becomes an issue, those kinds of things. We look at deeply into the hormones, way deeper than on average people look. And frequently we uncover a lot of things that have been overlooked with patients.
But also supplements help when you're on hormones to go through the body in the right pathways, right? So we're going to do a show on supplements in next month.
Yeah.
Nice.
Yeah.
Of course,
She just wrote a check that I have to cash.
Next month is tomorrow, because here we are on the 31st of July already.
Neil's coming to do a show.
Oh, right. Neil's
Yeah.
coming. Right.
Yeah.
Okay, cool.
Do people, though, are there symptoms usually that people will have that they just can't take anymore? Maybe I guess by default, you would see a doctor, right? Your friends, hey, sometimes, well, maybe you should go get a doctor. Talk to your doctor. Have a physical. Go to, and what is it, though? Is it they come to you typically after everything has failed, or do they come to you first, usually?
Yeah. It varies. Occasionally, we'll have somebody come to the office that have made the rounds, made the allopathic rounds and gotten nowhere. They'll have a cluster of symptoms. Usually it's a very deep cluster of symptoms, and they're looking for a single answer. But usually it's people who have gotten to a certain age, and a lot of times, one of the classic ones is the guy who goes to the gym 3 times a week. He's really walking the walk from an exercise standpoint, but he's realized he's not building any muscle anymore. He used to be energized when he went to the gym, and now he's so fatigued that he takes a nap over his breakfast, those kinds of things. So they notice fundamental changes about the way their body is working, and they wind up in our office because they understand that if they just go to their regular doctor, they're not going to get much help. Because they know that we approach this stuff from a different direction. So a lot of patients are like that. We see women who are in the throes of menopause and are just miserable, and their families are miserable, and they understand that we're going to help them with that kind of thing. So occasionally it's someone who has made the rounds, and a lot of times they're convinced they have something that they don't really have. Lyme, for instance, is the classic one. I've been to 15 different doctors, and they all test me, and the tests are all negative, but I know I've got Lyme disease, Okay, well, all right.
Self-diagnosis?
Right,
Yeah,
I'll text Francesca, who's up in the front desk, say, give me another couple hours here. This is going to take a while.
I also think men sometimes, that they're either going through a crisis, they're getting divorced, or a couple of their buddies have died.
Yeah, that's a big
so
one.
they realize that their lifestyle's not exactly healthy, so they really want to make changes.
Yeah.
It's kind of a wake-up call, I think.
Definitely, yeah.
But are there physical symptoms?
Yeah, fatigue mostly,
Okay.
erectile dysfunction. We've
Okay.
talked about that
Insomnia.
before. Insomnia, yeah, lack of sleep. Libido. Libido's a big one, especially with women. I love my husband, but I love my husband, but I'm just not interested, and it's becoming an issue. Those kinds of things. Typically, because, what are we used to in America? We're used to not seeing our doctor until we feel a very specific symptom for which we do not have an answer, right? Think about all the times you've been to the doctor. Aside from that yearly checkup, it's always a fever or sniffles or something like that. These are more subtle symptoms. They're more about the way your body works. A lot of these people are very in tune to the way their body works because they eat fairly cleanly, let's say, or they do go to the gym on a regular basis, and they're just noticing that they're not getting results. Remember when you were 28 and you could skip a meal and lose 5 pounds? Remember those days?
Oh man.
Okay, we all remember those days, right?
All too well.
Yeah, you're not there anymore, brother, and
No.
that's part of it. You know, I mean, it's much more profound thing, but usually it's supple, much more subtle. I mean,
And I think women need more of a hands-on kind of babysitting approach because we're complicated. Our bodies are complex. Menopause is complex. It's fine-tuning on a regular basis, I think, for women. There's a lot of things going on at the same time when we go into menopause. So.
Yeah, men are a little bit simpler.
Yeah.
As long as they're building muscle, and getting erections, they're
The
pretty
women
good.
out there, don't be afraid.
I've heard you talk in the past about functional medicine. Please remind me, what is that?
Functional medicine. It's a wastebasket term, I think. I think chiropractors were the first one to use the term functional medicine. We adopted it in our practice because what we do in our practice speaks more to addressing the underlying causes for what's causing a person's symptoms, as opposed to categorizing their symptoms and finding a pharmaceutical to fix the symptoms. Okay, depression's a classic example. What does the average woman who's going through menopause get from her gynecologist of all people? You know, who would think, right? When they are in the midst of menopause, they get antidepressants, when in fact it's hormone withdrawal that is causing their problem. And so, rather than giving them an antidepressant, which is a simple prescription to write to get them back in the parking lot, our approach is much more complicated. Delve deeply into what's happening with them metabolically and socially and all the other aspects of their life, and help them navigate through it to a point where they're feeling better and kind of globally feeling better. So functional medicine is really about function, maintaining, acquiring, reacquiring function in a situation where you're basically your body's not functioning for you properly. You know, they say in our business we say pills for ills because that's what people get. You know, they pretty much get a pill for pretty much every symptom that you've got. And I'm not denigrating the allopathic system. These people, these doctors.
Well, no, you're an allopathic doctor,
right? And these doctors, their hearts are in the right place, but to a certain degree, their hands are tied by the notion of standards of care because they get paid by insurance. You know, if they don't walk the walk in terms of how they treat a patient, so on and so forth, they don't get paid. They don't feed their families. You know, and that's what medical schools are teaching these days, also. So even kids come out of medical school with this idea in mind that they're catalog a patient's symptoms and then work on relieving the symptoms.
All right, so if somebody's listening to this for the first time, I kind of know the answer to this, so bear with me. I'm trying to speak for the person who has only caught on to the show over the last maybe few weeks. They're going to say, okay, well then the opposite of allopathic, I'm not going to go see a medical doctor, or I'm going to try alternatives. A naturopath, homeopath. Can you distinguish the two? And then how does it contrast to your area, what you're doing with HyperFit MD?
We kind of have one foot in all of those fields, you know. I mean, I'm an allopathic physician, but we definitely, I'm a believer in naturopathy. Much of what we do with supplements comes right from the naturopath field book. Homeopathy is a little bit different. Chiropractors improve people's lives every single day. I mean, you don't go to a chiropractor for colon cancer, but you know something? If your back hurts and all you've been offered by an orthopedic surgeon or a back surgeon is an operation, the first thing I would do is go see a chiropractor. Find myself a good chiropractor to help me feel better.
So you believe in chiropractic?
Absolutely. Acupuncture. An acupuncturist in Florida pulled my butt out of the fire where nobody else could. I have this thing called trigeminal neuralgia. That's another hour-long thing. But I was in a lot of pain in Florida and had no access to anything, and stumbled into an acupuncturist's office. In an hour, I was feeling better.
Wow.
It was amazing. So, yeah, we kind of had and if I think somebody needs an acupuncturist, I'm going to send them to one. I don't do acupuncture, but put it this way, and we've had this discussion before. shamans and witch doctors and old ladies with herbs,
spiritualists.
Spiritualists have been treating people and making them feel better for 50,000 years. The concept of peer-reviewed, double-blind data collection, waiting 10 years while you blah blah do all the other stuff like that is the scientific way of approaching medicine. It's a great way to do it, but by the same token, there are other ways of skinning every cat.
Folks, you are listening to HyperFit MD Radio. This is Dr. Charles and his wife, Francesca Guglin. They are located in Milford over on Noble Avenue. You can give them a call at area code 203-890-9777. You can also check them out online at hyperfitmd.com. I'm Gary Byron. I mean, are there typical, let's say a woman comes in and she's, I don't know, in her early to maybe mid-40s. She's mid-40s. She's put on a couple of pounds. She's got migraines. Maybe her libido has decreased, not 100%, but a little bit. And a doctor just says, well, I'm going to put you on this medication. Another doctor says, well, I'm going to put you on this for that. And medications interact with each other. And I know that's part of a doctor's, they've got to understand all the medications that you're on in order to do that. Is that typical? Is that cause or for concern? Is that sound like it could be caused by menopause? And then I can ask a similar question. A guy comes in and maybe he's got a spare tire around his belly. Maybe his erection can't last as long as it used to. Maybe stress from work contributes. Are these typical symptoms? I'm talking, and I'm being very, very general here because for the sake of the radio show, I can go into greater details. But are these some of the symptoms that you hear from each sex?
Every day.
Every day.
Every day. And it's interesting that you mentioned, take the guy with erectile dysfunction, for example. He comes in. He's 50 years old. He's been doing okay up until about 2 or 3 years ago. He kind of waited for it to go away for a couple of years and then was afraid to talk to his doctor about it, so on and so forth. And he comes in and he's got that spare tire. He's got visceral fat, which is an inflammatory fat that is contributing to insulin resistance and all the other things that lead to adult onset diabetes in older age. He's on 3 different medications, 2 for hypertension. One, he's been on Zoloft forever because he had a depressive episode and he never came off it. And he's got problems at home with his wife. The two of them are not really getting along. So, and I look at this guy and I say, okay, yeah, you got erectile dysfunction. We have procedures that will help you with that. But before we approach this from a procedural standpoint, we have to set the stage for success. How do you set the stage for success? First of all, you look deeply into their metabolism, blood work, the stuff that we talked about before. If they have hormonal issues, you adjust to hormonal issues. And then I say, okay, you're on 4 medications. 3 of those cause erectile dysfunction. 2 of them are antihypertensives. Let's help you get rid of that belly fat. Let's help you lose 30 pounds of fat so that you're off those antihypertensives, okay? Mm-hmm. It's a long trip. It's not a trip around the corner. It's a long trip. Took you a long time to get there, but let's go take another route here and improve your overall health. And there's a significant chance, number 1, that your erectile dysfunction is going to go away. But number 2, if that's still part of the problem, once we've taken care of some of this other stuff, then we'll take a procedural approach to erectile dysfunction, shockwave therapy, P-shots, things like that, because we've already set the stage for success with those particular procedural approaches to your erectile dysfunction. In women, it's the same thing. Frequently, we have a very specific symptom that brings us to a doctor's office, but we've accumulating etiology, causes of those particular symptoms over a lifetime of physical abuse, okay? Just bad eating, no exercise, stress. In America, we're proud of our stress. We brag about how much we work, we say, oh man, 70 hours. I put 70 hours in this week, that kind of thing. Go ahead.
I think in the next show we should talk about pharmacogenetics. I think it's a really important part.
Yeah, we can do that.
Of
labs
sure. that nobody really addresses.
What did you say? It's called what?
Pharmacogenetics.
Pharmacogenetics.
Yeah,
Okay.
pharmacogenomics or pharmacogenetics. It is we can talk about it now. It's one set. It's interesting. It's amazingly helpful in terms of, because in America, the average 65-year-old in America is on 10 pharmaceuticals, either over-the-counter pharmaceuticals or prescription pharmaceuticals. Pharmacogenomic study tests about 100 different genes. It gives us a lot of information. It gives us your risk for Alzheimer's disease. It gives us your risk for metabolic problems like diabetes. Gives us your risk for adult onset mood disorders, so on and so forth. But also what it gives us is a printout. It's a kind of a 4-page printout. There's 4 columns. Column 1 is the different categories of medications, okay? Antidepressants, antihypertensives, statins, so on and so forth. Column 2 is a green column, which tells us genetically these are the medications that you can take because you can metabolize these medications. Then there's a yellow and a red column. Go all the way to the red column. There's a list of medications that you should never take because you're incapable of metabolizing those medications. Every single person on the planet should have pharmacogenomic studies done. But guess what? We used to do it on all our patients. And then about 2 years ago, insurance stopped paying for it.
You do take insurance, right?
We take
HSA or
Yes.
okay.
Yeah. For the labs, we take insurance. But
Gotcha.
the rest of insurance doesn't pay for anything that we do.
This is only part 1 of a 2-part show here. I know 'cause we're running out of time. I want to make sure that I provide you some contact information, but this is vital, particularly if you're newer to the show. Kind of hitting the reset button. So we'll continue with this next week. Folks, if you'd like to get in touch with Dr. Charles Guglin, it's pretty easy. Just send him an email at cguglin, that's CGUGLINMD, at HyperFitMDAMC.com. You know what I do is I tell people to check out the website first, HyperFitMD.com. Once again, www.hyperfitmd.com, located at 88 Noble Avenue, Suite 105 down in Milford, Connecticut. And, of course, their phone number is 203-890-9777. Once again, 203-890-9777. For Dr. Charles and Francesca Guglin, I'm Gary Byron. Until next Saturday morning,